Hello everyone, I'm Choi from Ulsan Medical Center, Seoul, Korea. Thank you for inviting me to APCIS, a wonderful symposium. I will present the topic of safety issue of reoperation in patients with congenital heart disease. I have no disclosure. The number of redo cardiac surgery in patients with congenital heart disease continues to increase. The recent surgical results of redo surgery is improved. However, redo operation is still a challenge in high-risk patients. Thoughtful surgical planning and proper preoperative imaging are critical to a safe operation, and specific operative strategies can reduce morbidity and mortality. Today, I focused on the specific issues of massive embolism and aortic rupture during reoperation. Let's see the case. The patient with a history of tetralogy repair underwent pulmonary valve replacement for severe pulmonary regurgitation. Postoperatively, severe brain edema was developed, and it resulted from massive embolism. Massive embolism is a rare but devastating complication in open-heart surgery. Patients with congenital heart disease undergoing reoperation can suffer massive embolism because of occult atrial or ventricular septal defects and high prevalence of right heart procedure such as pulmonary valve replacement. The instance of occult septal defect is unknown, but we often encounter occult septal defect in real practice. Occult septal defect can result in systemic air embolism if RA, LV, or pulmonary artery is injured inadvertently during empty beating under cardiopulmonary bypass. A variety of perfusion strategy can be used in right heart procedures such as PVR. If occult septal defect exists, empty beating right heart procedure can put the patient in danger of massive embolism. Also, LA auricle can be injured during dissection around pulmonary artery. Besides general measures to minimize embolism, specific measures must keep in mind to minimize the risk of massive embolism in congenital heart surgery. At first, do not trust echo report and even OP record. It is safe to regard occult septal defects can always exist. To prevent air entry into a decompressed heart, inadvertent cardiotomy should be avoided, and it is essential to maintain CVP more than 6 to 8 mm mercury and use vacuum-assisted venous drainage very carefully. The avoidance of empty beating heart surgery, such as aortic cross clamp or fibrillatory heart, can eliminate the risk of embolism. There are several measures to save the patient with massive embolism. However, the best management strategy for the complication is prevention. The various cardiovascular injury during reoperation is associated with operative morbidity and mortality. Among them, aortic rupture is one of the scariest ones in cardiac surgery. Let's see the case. The patient with history of convergent arterial switch operation underwent reduced surgery for infective endocarditis with pseudoaneurysm of great vessel. After reduced sternotomy, aortic rupture from pseudoaneurysm was encountered and compressed manually. How can surgeons deal with it safely? Aorta can be injured during congenital heart surgery because aorta is dilated and positioned anteriorly in conotruncal anomalies. Calcified alveoli may be tightly adhered to the aorta, especially in patients with multiple previous operations. Prevention of aortic rupture is of paramount importance. Preventive measures should be started from previous surgery such as aortic coverage using PTFE membrane. Aortic injury during division of the sternum seems most dangerous. Measures for safe restenotomy included alternative or additive incision and use of peripheral cannulation. Take your time during dissection around the aorta. The first step to manage aortic rupture is to take a deep breath. In small children, primary repair can be tried because aortic wall is soft and compliant. In cases of adult patients, aortic rupture point is compressed manually or by sternum, and cardiopulmonary bypass is initiated and body temperature is lowered. LV band is inserted to minimize the risk of LV distension. Total circulatory arrest is necessary to achieve optimal surgical conditions. Cerebral and myocardial protective measures are taken during aortic repair. The number of reoperations in patients with congenital heart disease is rapidly increasing. Safety is the essence in reduced surgery. My presentation was focused on the two issues of massive embolism and aortic rupture. Thank you for your attention.